So I don't have a formal presentation. I'm just going to tell you how I got where I am. I want to give a little more background on myself. I think it's interesting how I've evolved over the years. I was a non-traditional medical student, so I did not go to medical school straight out of college. I went to Virginia Tech for undergrad and majored in fraternity parties and all kinds of other things. So my grades were not great when I finished med school, but I ended up getting a really good job with the federal government. And I worked at the National Institutes of Health for 6 years and lived in the Washington, D.C. area while I did that. It wasn't all bad working for the federal government. It was mostly bad, but it wasn't all bad. They paid for my education at Johns Hopkins University. I got a master's in public health from Johns Hopkins University. Thank you, taxpayers. And they did a pretty good job of indoctrinating me into the belief that the solution to the woes of our healthcare system was a single payer system. So I went into medical school sort of with that viewpoint that, you know, the answer was for us to evolve and adapt a single payer system. My views very quickly changed when most of my rotations in third year were at the VA hospital in Hampton, Virginia. So I'm sure I don't have to elaborate on that. Everyone's aware of that disaster if you've spent any time at the VA. So eventually I finished residency. At that time I had just married my husband. Well, we got married right before residency. I was 35 years old. I knew I wanted to have children. And so when I graduated residency, it made the most sense for me to join a hospital system because I had a 9-month-old and I knew I wanted to have more kids. So I needed the paid leave in order to expand my family. So my first job was in a rural area in Carrollton, Kentucky, which is not very far from here, actually. It's about 50 miles. It's exactly 50 miles south of Cincinnati and 50 miles north of Louisville. And Chris, my husband, he always knew he wanted to do police in Louisville, so we sort of split the distance. Carrollton was wonderful for a lot of reasons. I enjoyed rural medicine very much because I was able to do sort of a full spectrum of family medicine except for the OB part. But I worked for a hospital system. So very, very soon within that 5 years that I was there, I realized that, you know, the real point, the real pressure was for me to see as many patients as possible and to send my patients to their hospital system for MRIs, for specialty care. Well, their hospital was in Indiana, so I mean, it just didn't make any sense for me to send my patients to that hospital, especially when their MRIs were $2,500 and they could get one here in Kentucky for less. So I ended up just having a lot of anxiety and reading more about other options for primary care, and then was reading a lot about the patient-centered medical home. And actually, I need to talk about the addiction part a little bit here. This is where my interest in addiction started in Carrollton, because when I was practicing in residency in Virginia, in Norfolk, Virginia, and Portsmouth, Virginia, we did not have doctor shopping, I guess, for pills. The regular drugs, heroin, crack, marijuana, everything was available because of where Norfolk was located. So I was not aware of the pillbilly phenomenon. And what was going on with OxyContin and Xanax and everything that was happening in Kentucky when the opioid epidemic really started. So when I started working in Carrollton, within 2 months, I quickly realized that everybody in the town was on a cocktail of hydrocodone, Xanax, Soma. Some of them were on Adderall, and that's why they needed the Xanax to help them sleep at night, because the Adderall revved them up. And it was problematic because I really didn't feel good about it. I wanted to try to taper people off of these medications. I started running Caspers and realized that many of these patients who, you couldn't tell by looking at them that they had an addiction, but you could tell by looking at their Casper that they had an addiction. And the Casper is the benefit is the, what do they call them? PDMPs is the acronym, but it's where you can look and you can see what prescriptions people have had filled. So that's when I decided I learned about buprenorphine, which is also known as Suboxone. It's more commonly known as Suboxone because that was the first brand name version of buprenorphine, and decided to become certified to prescribe it. And Chris, my husband, who's here, he kind of pushed me in that direction because he was tired of hearing me complain about the pill seekers, and he said, why don't you just do something about it, address the problem instead of complaining about it. So I became certified, reluctantly started to prescribe buprenorphine for opioid addiction, and then very quickly loved it. It was amazing. It was the first time in my career as a doctor where people would tell me, you saved my life. This medication has saved my life. I'm able to go on vacations with my family now because I have money in my pocket. I'm able to take my daughter to lunch. So it was wonderful. The problem was the organization that I worked for, the nonprofit hospital that I worked for, could not bill for those services. At the time, addiction treatment services were not covered by any insurance plan in Kentucky. So they did not want me to increase that panel of patients. Then I started working for a company called Self-Refined, who charged cash for those addiction services, and I love that because that was when it connected. Wow, I can actually spend time with this patient and talk to them and have a relationship with this patient, and I don't have to worry about coding or billing or 99215, 992s. I don't remember the numbers. I've blocked it out, and so that was very rewarding. So I was still doing that once a month for that company. Then I worked for a patient-centered medical home, which was a disaster. And then I didn't see Josh speak in Louisville because I guess I didn't get the email about that meeting. I was at the time working for the patient-centered medical home, seeing 25 to 30 patients a day, very frustrated, coming home, bringing my work home with me because the EMR was very complicated. We had all scripts, and doing work at home. But I did see the video online, so that was when I started thinking about doing DPC. And my model is pretty much exactly like Tracy's and Dr. Josh's, except I do the addiction treatment now as direct pay as well. What I do is I charge extra for addiction treatment. The membership fee is a little bit higher for the addiction treatment because I do see those patients more often. Especially at the beginning, they'll come in weekly. Then sometimes it's biweekly. At the most, or at the least, I see them once a month. So the charges are just higher for that membership fee. And then if they want me to do direct primary care for them as well, they pay just a little bit more. It's like $25 extra if they want all of their services covered. The medication is covered through their insurance company, so I have not gotten away from prior authorizations, which is a bummer. But at this point, there's just not a real way to do that. I could dispense buprenorphine within my practice, but my law enforcement husband does not like the idea. I don't know anything about guns. We have some in the house, but I don't know how to shoot one. So, but I mean, honestly, that concern is real. We've never had any trouble with any kind of episode with the police. You know, a lot of times people will say to me, why would you want to treat addiction? I even went on an interview in Richmond and talked a little bit about opioid addiction and how I treat it, and I enjoy treating it. And the woman looked at me and she said, we don't prescribe pain pills, we don't prescribe any controlled substances because we don't want those people in our waiting room. And as a Christian, that really hurt my feelings, so I did not take that job. And it's just not true. It's just not true. You can't tell the difference. The reason people will say derogatory things about methadone clinics or Suboxone clinics is because they know that's who's going in there, and there is a stigma around addiction. In my practice, you would not know if the patient was coming in to see me for some other problem or if they were coming in to see me for addiction. You would not know. Just going along with what Tracy was saying and how wonderful it is, it's just, I really can't believe it some days. This has always been my dream. I became a family physician because I wanted to build relationships with people. I wanted to see the whole family. I wanted to do comprehensive care, and I'm able to do that for the first time since I've been practicing medicine. It's been 2 years. I've gotten to the point where I'm not going to take any new patients, so I'm looking to hire another doctor, and she's probably going to work part-time. We've met with some employers locally. We met with the county, Oldham County, where we live and practice, and they're interested. They're very interested in saving themselves money and providing better care for their employees, which is exciting. The Medicaid problem is frustrating because we do feel that we could save Medicaid a lot of money, and that we could do a better job of caring for that population than the traditional healthcare system is doing. So if any of the attorneys in the room have any advice on how to get around that issue or to make the case in a more effective way to the politicians in Frankfurt, that would be great. I think Secretary Glisson is on board. She's definitely on board. But there are some people within the administration who are not, and there are some people in the legislature who are not. They believe that Medicaid patients should not have to come out of pocket for anything. I did want to mention, for people who are looking to start a direct primary care practice or a direct care practice, anything, any physician can become certified to prescribe buprenorphine. The first year you can see up to 30 patients, and then you can apply the second year to see 100 patients. I can see 275 patients because I became board certified in addiction medicine. So I actually took a board certification exam. But the reason I bring it up is when you're starting your practice and building it, if you need extra revenue, it's an easy way to do some moonlighting and bring in some extra revenue. That you can work at addiction treatment facilities, and usually they'll pay you by the hour. And they pay a decent amount. Many of them still do not bill insurance, so you don't have to worry about the headaches of all of that. And then also, if you were to decide to do it within your practice, I could help you do that. It's really pretty seamless, and it does bring people in the door because right now more people are dying of opioid overdose in our country than of anything else. So it definitely brings people in the door. I do want to thank my husband Chris for being my chief operating officer for absolutely no money at all, and for believing in me and believing that I could do this. I'm sure you realize it was kind of scary, but I have no regrets. I want to thank Jesus because I couldn't have done this without Jesus. I actually got baptized in December of 2015, so that has made a big difference. Thank you.